Hi, my name is Joel Gallagher. I'm one of the physicians here at the Allergy and Asthma Center,
Hi, my name's Ann Ams. I'm a nurse practitioner at the Allergy and Asthma Center.
and we are going to talk to you about food allergy treatment options.
Although we can test for hundreds of different foods, a majority of food allergies are covered by 9 foods that cover 95% of all food allergies. This includes soy, eggs, peanuts, tree nuts, fish, shellfish, wheat, milk, and sesame, which was just added about 5 or 10 years ago. The different percentages of these foods varies according to a nation's diet. For instance, shellfish allergy is more common in the Chinese culture, whereas peanuts and other legumes are more common as food allergies in India.
The prevalence of food allergies varies in the US according to the study that you're looking at. Oftentimes, these studies are parent reported, and if you've ever been a parent or worked with parents, you can understand why these results could be skewed. The strongest studies, obviously, are oral challenge studies confirming a food allergy, but it's difficult, verging on unethical, to convince patients to eat the food allergy, knowing that it could possibly cause anaphylaxis. Food allergies affect approximately 8% of children and 11% of adults in the US. Half of these patients report having had at least one severe allergic reaction in their lifetime. This data is a few years old, but it's estimated that food allergies cost the US healthcare system $24 billion annually. There was recently a large worldwide study led by Dr. Ruchi Gupta at Lurie Children's Hospital. She does the majority of the epidemiologic studies in the field of food allergy. She gathered data over the span of 20 years that included around 93,000 patients. That showed a worldwide prevalence varying from 2% in Germany up to 8.7% in China.
Patients with food allergies don't feel daily symptoms of their condition compared with other chronic conditions. Some of the day-to-day issues include stress, anxiety, and depression. Anxiety is the biggest component of this emotional distress. This was especially noted in mothers of food allergic children. One study even found that anxiety is more intense for families with allergic children compared with children with type 1 diabetes.
The standard treatment option, even when I was in fellowship training relatively recently, was continued avoidance. We would see patients once a year and then test and consider a challenge. More common than not, the testing would still be positive, and we would recommend continued avoidance, refill the epinephrine, and fill out their school forms. There really wasn't a lot that we could do. Thankfully, there are more options now. Epinephrine remains a cornerstone of treatment. I just want to note here that we have several options for epinephrine injectors today, including a relatively recently approved nasal epinephrine that doesn't even have a needle. Before we talk to patients and their families about food allergies, we want to ask them what their goal of treatment is. If their goal is just to prevent accidental exposures or cross contamination, that changes what we do as practitioners. We don't have to be as aggressive with the dosing, and it changes the duration of the treatment. However, if families and patients want to be able to eat the food as much as they want, that changes the risk versus benefits discussion. It might also change any adjuvants that we add to the treatment plan, such as biologics.
Alternatively, if they want to continue to avoid, and it's an easy food for them to avoid, then epinephrine, if needed, is by itself the treatment. You definitely want to get the patient involved in the decision-making process, if possible. This is especially true for patients older than 4 to 5 years old. We had one patient who was 7 years old when he started. He made it all the way through the process, and then he showed up with his mother in the clinic for his follow-up visit. And mom said that he had been hiding his doses underneath his bed, effectively negating all the work we had done.
Oral immunotherapy is the most utilized treatment now, so we're going to start there. This is a general overview of the process. The first day is the rapid escalation phase, where patients are given increasing doses of the allergen every 15 minutes until they reach a certain point. Then they come weekly for the buildup phase until the maintenance point is reached. Again, it all depends on what the goal is. It's much fewer steps to reach a point of protection against cross-contamination, which is considered about one peanut in the case of peanut allergies, versus protection against accidental exposure, which is generally considered about 3 peanuts in the case of peanut allergies. We may consider a challenge to OIT approach where we skip some steps in the process. This is for patients who have a history or labs that are not entirely consistent with an IgE mediated process. If the history is not convincing or the labs are on the verge of being positive, we'll do this challenge to OIT approach, which might end up where the patient can eat the food as much as they want without having to go through the whole OIT process.
There are several things to consider before beginning OIT. The first visit is the longest, about 4 to 5 hours. During this visit, we start with a tiny amount of the allergenic food and increase the dose once every 20 minutes. We measure vital signs and do a physical exam between each dose. And the patient goes home with a specific dose and receives that dose at the same time each day. Subsequent visits are about 1 hour in length each week. We give a larger dose and monitor for 1 hour each week. During the first several weeks, the amount of the allergenic food is so small that it must be mixed with a liquid and, and maintained in liquid form. These mixtures do not contain preservatives and must be refrigerated. We provide the food during this time. However, with dosing advancing to a solid form, the patients will be expected to purchase a small scale as well as provide the food. We will have a lesson about how to weigh the appropriate dose during this time. Activities need to be restricted for 2 hours after dosing to decrease the risk of reaction. Home and clinic dosing need to be given about the same time each day. This time can be gradually changed if needed. After reaching the goal, the patient will continue to consume a maintenance dose of the food daily, and labs will be drawn about 6 months after reaching the maintenance dose to monitor progress.
OIT has been evaluated in other foods in smaller studies. Egg and milk have a similar success rate as peanuts and tree nuts. Milk OIT has a much higher rate of reactions. We've definitely found this to be the case in our experience. Adverse events from OIT include anaphylaxis, which is a severe allergic reaction, as well as eosinophilic esophagitis. We have several screening questions at each visit to make sure that we're not missing anything. The quality of life is markedly improved with patients who undergo OIT.
We have been working with the Food Allergy Support Team, or FAST, since 2019. This group was founded by Dr. Richard Wasserman about 15 years ago. He was frustrated by the slow pace at which oral immunotherapy trials were making it into the clinic. So he and his team came up with protocols to various foods based on the data. There are hundreds of allergists in this group, and they now provide us with nearly 100 food protocols. We use this service to communicate with other allergists across the country about the management of food allergies.
We'll talk about sublingual immunotherapy next. This is administered via a dilution of protein, which is placed under the tongue and allowed to absorb sublingually. It's typically held for 1 to 2 minutes and then swallowed. Doses are advanced by 25 to 100% each week or every other week until the maintenance dose is reached. Protocols are generally in the 2 to 4 milligram range and therefore much smaller than OIT. This leads to fewer reactions, but that's exchanged with lower amounts tolerated in the end. It's a good option for patients who cannot make the multiple visits work for the traditional OIT. We've been using omalizumab in the asthma world since the early 2000s. It works by binding IgE, which is the allergy antibody, reducing its interaction with various immune cells. It's been approved for asthma for over 20 years, and a year ago it was approved for treatment of food allergies. The Outmatch study was the pivotal trial that got it approved. Xolair is not really a cure, but more of a bridge in food allergy treatment. Studies have also looked at combining omalizumab with oral immunotherapy. Omalizumab has been evaluated as a pretreatment option for OIT, as well as use during the buildup phase. In general, omalizumab tends to decrease the reactions during the updosing phase of OIT and increase the total number of patients who reach the maintenance dose. There are still a lot of unanswered questions about omalizumab and food allergies, but we've used it in high-risk OIT patients, especially when we're doing more than one food. Thank you so much for joining us today. We didn't include a lot of food allergy treatment options that are on the horizon, but hopefully some more will be approved in the coming years.
All right. You feel satisfied?